Hello everyone, I'm Dr. Bhagyashree from the Department of Oral and Maxillofacial Surgery, Sri Balaji Dental College and Hospital, and I will be talking about hemorrhage and its management. What is hemorrhage? It denotes the escape of blood from a blood vessel, and any damage to the vasculature leads to the outflow of blood. Blood carries oxygen and nutrients to the tissues and is vital for body functions. So, loss of blood due to any reason beyond a certain point is potentially life-threatening and may lead to dysanguination, which is known as blood loss to a degree which is sufficient to cause death. Classification of hemorrhage. So, depending on the source of bleeding, it can be divided into external and internal hemorrhage. External, when the bleeding is revealed and seen outside, like in epistaxis. Internal, when the bleeding is concealed and not seen outside, like intracranial hematomas. Depending on the nature of the bleeding vessel, it can be divided into arterial, venous, and capillary hemorrhages. Arterial hemorrhage is characterized by bright red color, and blood is emitted as a jet with each heartbeat. Venous hemorrhage is dark red in color, but the blood flow is steady. Capillary hemorrhage is again bright red in color, but it is a generalized ooze of blood instead of blood flow. Depending on the time of hemorrhage, it may be primary hemorrhage, which occurs at the time of trauma or surgery, reactionary hemorrhage, which occurs within 24 hours of the trauma or surgery, and secondary hemorrhage, which occurs about 7 to 14 days after trauma or operation. Depending on the amount of blood loss that happens, mild hemorrhage, which is blood loss of less than or equal to 500 milliliters, moderate hemorrhage, where blood loss is ranging from 500 to 1000 milliliters, and severe hemorrhage, where the blood loss is greater than or equal to 1 liter. Depending on the speed of blood loss, it may be acute hemorrhage with massive bleeding in a short span of time, or chronic hemorrhage with slow bleeding, which is small in quantity but for a long period of time. Depending on the percentage of blood loss, class 1 up to 15% blood loss, class 2 between 15 to 30%, class 3 between 30 to 40%, and class 4, which is more than 40% of blood loss. So the etiology of hemorrhage may be trauma, infections, congenital malformations, surgeries, which is intraoperative or postoperative. It may be due to systemic diseases, abnormalities of clotting factors, or abnormalities of platelets. Hemostasis. The mechanism of cessation of the extravasation of blood is known as hemostasis, and it involves four important steps. The injured blood vessel undergoes constriction due to spasm. There is activation of platelets and formation of a platelet plug. This leads to primary hemostasis. Activation of the clotting mechanism happens and formation of a clot occurs, leading to the completion of the secondary hemostasis. Then there is fibrous organization of the clot, also known as retraction of the clot. So you can see there is vasoconstriction, primary hemostasis, then secondary hemostasis, and thrombus and antithrombotic events, which is basically retraction of the clot. Primary hemostasis, the process of platelet plug formation at the site of injury, is known as primary hemostasis. It occurs within seconds of injury and is important for the stoppage of blood from small arterioles, venules, and capillaries. There is platelet adhesion, release of granules, and platelet aggregation, resulting in the formation of a primary hemostatic plug. Secondary hemostasis, activation of clotting process in plasma that results in formation of fibrin, which strengthens the primary hemostatic plug. It is completed in several minutes and is important in bleeding from larger vessels. Some substances promote clotting, which are known as procoagulants, and some prevent clotting. These are known as anticoagulants. There is a complex interaction of various factors of coagulation in the formation of clot. There is an intrinsic pathway and an extrinsic pathway, and a common pathway for coagulation mechanism. The intrinsic pathway, there is surface contact. So factor 12 is turned into factor 12A, which helps in the conversion of factor 11 to 11A. That in turn helps in the conversion of factor 9 to 9A in the presence of calcium ions. Then factor 8, calcium ions, and PF3 are involved. In the extrinsic pathway, there is tissue damage, which causes the tissue factors, factor 7 and calcium ions to be released. This all leads to the common pathway where factor 10 is converted to 10A, and in the presence of factor 5, calcium ions, and PF3, prothrombin 2 is converted into thrombin, which is factor 2A. This helps to convert fibrinogen to fibrin monomers, and this causes fibrin degradation products. Coagulation mechanism can be broken down into a series of 4 reactions. The first reaction is the intrinsic or contact phase of coagulation. It involves factor 8, 9, 11, and 12 along with calcium and plasma proteins. Partial thromboplastin time screens this. Reaction 2. Extrinsic pathway for initiation of coagulation. There is release of tissue thromboplastin from injured tissues. Protease complex formed between factor 7, calcium, and tissue thromboplastin, which activates factor 10. Prothrombin time screens this. There is reaction 3, where factor 10 is activated by proteases generated in the previous 2 reactions. Reaction 4. Prothrombin is converted into thrombin in the presence of factor 5, calcium, and phospholipids. The main role of thrombin is conversion of fibrinogen into fibrin. It also activates factor 5, 8, and 13 and helps in platelet aggregation and secretion. The clinical evaluation of a patient with coordinated history and physical examination provides valuable clues. The history should include the following questions like, is there any family or personal history of bleeding tendencies? Has the patient undergone any surgeries or extractions? Any history of hematuria, gastrointestinal hemorrhage or epistaxis? Is the patient on any kind of medication? You have to note for any splenomegaly or hepatomegaly, hepatic insufficiency must be assessed and there should be an assessment of skin and mucosal surfaces. Laboratory tests may include bleeding time. So patients with bleeding time of more than 10 minutes have an increased risk of bleeding. Various methods for measuring bleeding time include the IV, Duke, and the template method. Bleeding time is prolonged in thrombocytopenia, von Willebrand's disease, and platelet dysfunctions. Platelet count. A normal count of 1.5 to 4.5 lakh per cubic millimeter of blood is a normal platelet count. When count becomes about 50,000 to 1 lakh, there is mild prolongation of the bleeding time. Patients with count of less than 50,000 have easy bruising. Minor oral surgical procedures can be done if the count is above 80,000 to 1 lakh per cubic millimeter. Prothrombin time or PT. Normal PT is usually 12 to 14 seconds. It is prolonged, however, in patients who are on warfarin anticoagulant therapy, vitamin K deficiencies, or deficiencies of factor 5, 7, 10, prothrombin, or fibrinogen. Plasma thromboplastin time or PTT. It is prolonged in hemophiliacs. The normal value is less than 45 seconds. It is relatively insensitive to changes in intrinsic coagulation system. Small changes in PTT may be of great significance. Methods of achieving hemostasis. This may include chemical methods and mechanical methods. Mechanical methods include pressure, hemostat, sutures, and ligation. Chemical methods include local agents including adrenaline, thrombin, Surgicel, Oxycel, Surgicel fibrillar, and gelatin sponge. Microfibrillar collagen, fibrous glue, styptics astringents, alginic acid, collagen sponge, bone wax, or steam. Systemic agents that may be administered include whole blood, platelet-rich plasma or PRP, fresh frozen plasma, cryoprecipitate. Thermal agents could include cautery, electrocautery, cryosurgery, and laser. Thank you.